my goal is to utilize this information to share and to also help with your own personal studies, as I'm also using these for my own studies. So the topic here is nursing care and management of paralytic ileus, wound infection, and HIV/AIDS in maternity. So we start with a description of what really paralytic ileus is, and we know it is the failure of appropriate movement of bowel content. This condition may occur as a result of anesthetic medication or due to manipulation of bowel during surgery procedure. Typically, if ileus does occur, it is treated first non-surgically with bowel decompression by insertion of a nasogastric tube attached to intermittent or continuous suctioning. So it's also important as nurses that we do assessment. So on assessment, and some of the clinical signs that we'll see is vomiting post-operatively, abdominal distension, and of course absence of bowel sounds, movement, or flatulence. As I mentioned, post-operative vomiting. Patients commonly experience persistent nausea and vomiting following surgery, which does indicate impairment of bowel motility. With the abdominal distension, this is due to the accumulation of gas and fluid and bowel content that is noticeably and then abdominal distension due to reduced peristalsis. And typically you see this post-surgery, as I mentioned before. And then absence of bowel sounds and movement, you would detect this due to auscultation, which will then reveal diminished or absent bowel sounds. So now we look at some nursing intervention and medication management. And nursing intervention includes monitoring intake and output, and of course maintaining NPO status until bowel sounds return. Maintain patency of a nasogastric tube if one is in place, and of course we want to assess for patency and drainage per agency or whichever organization you're working at, their policies and procedures. We want to encourage ambulation, as we know ambulation helps to promote peristalsis so that we can get those content moving, and then administer IV fluids such as normal saline or an isotonic solution or parental nutrition, as however the primary healthcare provider prescribed for the patient. We also might want to look at administering medication as prescribed to increase in intestinal motility and secretion. For example, metoclopramide, and we can also utilize, as you know, metoclopramide is used for increasing gastric motility. And then erythromycin are commonly used to improve gastric emptying as well, and overall gastric intestinal transit time. These medications are used, as I mentioned before, to stimulate contraction in the stomach and the intestine, thus by helping food pass more quickly through the digestive system. Metoclopramide is a dopamine receptor antagonist. It also, as I mentioned before, stimulates acetylcholine release, which further enhance motility or mobility. It's often prescribed for gastroparesis and other condition with stomach emptying, where stomach emptying is low. And just to take a brief look at erythromycin, as we know, this is an antibiotic, acts as a mortallin receptor agonist. It stimulates contraction in the stomach and in intestine. It is effective in promoting gastric emptying as well, and is commonly used in the treatment of gastroparesis, like the other two medications that I mentioned before, metoclopramide, as being one of the medication that I mentioned. And then of course, using any prokinetic medication, we want to, like I mentioned before, the metoclopramide and the dopoperidone, to enhance gastrointestinal motility and mobility. So next we're going to move into wound infection, the description and nursing assessment. So wound infection commonly arises due to poor aseptic technique during surgery, sometimes contamination of the wound, or underlying conditions such as diabetes and immunosuppression, which place the client at risk or increased risk. So infection usually occur 3 to 6 days after surgery or post-operatively, and then you'll see purulent material may exit from the drainage or separated wound edges. Some clinical indication key signs include a fever or nursing assessment, and then you may find warm tenderness, painful and inflamed incision site. In addition, you will see edematous skin at the incision site and tight skin sutures, right? So another thing we'll see on lab also is elevated white blood cell count, and then infection, which does indicate that of course infection is present, or potential, or that is a potential to infection. Some nursing intervention we can implement at this time is to monitor the temperature, monitor the incision site for approximation of suture line, and then edema or erythematous, where bleeding and signs of infection might be present. Look at the ecchymosis sometimes, drainage, as I mentioned before. Then we want an approximation of the wound edges. We want to make sure that these things, and then if anything, the best approach would be to notify the surgeon if we identify that there is indeed sign of infection. We want to also maintain patency of the drainage. I meant to say potency of the drainage, and assess drainage amount, color, and consistency. We want to also utilize aseptic or asepsis technique when changing any dressing or performing any form of wound care or wound irrigation as prescribed on these patients. The nurse should also anticipate any prescription, and of course before starting any prescription such as antibiotic, we want to do a wound culture and a blood culture as well if infection is indeed suspected or identified. And then the nurse should then of course administer the antibiotic as prescribed by the primary care provider. So now we're going to look at HIV/AIDS in maternity. We're going to identify talk about the description and transmission process. So HIV is a causative agent of AIDS, or AIDS. Women infected with HIV may first show signs and symptoms at the time of pregnancy, or possibly develop life-threatening infection because normal pregnancy involves some suppression of the maternal immune system. So repeated exposure to the virus during pregnancy through unsafe sex practice or intravenous drug use can increase the risk of transmission to the fetus. 3 drug combination is utilized as part of the treatment process. We call this HAART, H-A-A-R-T. So that's H-A-A-R-T. It stands for highly active antiretroviral therapy treatment, which is monitored by infectious disease as specialists or disease specialists. It's recommended to reduce mothers to child transmission. So basically they utilize this to help reduce the transmission from mother to child. And then there's a drug also that is utilized. It's called zudovudine. It's recommended for the prevention of mother to child transmission. And then and this is also administered based upon the following recommendation. So antepartum, which is before birth or the beginning after 12 weeks of gestation. And then maternal AART is given to reduce the viral load to undetectable. And as I mentioned before, the AART stands for highly active antiretroviral therapy that is given to reduce the mother to child transmission. And then so intrapartum, they do intravenously during labor, is the zudovudine is given 1 hour before vaginal birth, and then 3 hours before cesarean section if the HIV RNA is greater than or equal to 400 copies per ml, or if it's unknown. So we want to give this intravenously during labor. And as I mentioned before, the zudovudine is given 1 hour before vaginal birth and 3 hours before a cesarean section if the HIV RNA is greater than or equal to 400 copies per ml or unknown, or if it's unknown. So just a little note, this may not be required if the HIV RNA is less than 400. So we might not give it if the load is less than 400 copies per ml, but it is given at the discretion of the provider. So a vaginal birth is acceptable if the viral node is less than 1,000 copies per ml. Otherwise, a C-section is recommended. Postpartum is recommended. So then in postpartum, in the form of syrup, is given in the form of syrup. This is postpartum to the newborn 2 hours after birth. The same zudovudine is given in a syrup form to the newborn 2 hours after birth, and every 12 hours for 6 weeks, depending on agency procedure. The newborn may need to be placed in a newborn intensive care unit, as we refer to as a NICU, to begin initial therapy. So just how do we diagnose, right? Tests is used to determine the presence of antibodies to HIV, include enzyme link immunosorbent assay. That's what we abbreviated ELISA, ELISA. And then we also use the Western blot and the immunofluorescence assay. This is the IFA. So these are just some diagnosis way in which we can diagnose. A single reactive ELISA, EILSA test by itself cannot be used to diagnose HIV. So the ELISA by itself cannot be used to say conclude HIV, and the test should be repeated with the same blood sample. If the result is again reactive, follow up with the test using a Western blot or the IFA, as I mentioned before. This is the immunofluorescent assay. That one of those two should be done along with the ELISA to confirm HIV. So a positive Western blot or IFA is considered confirmation for HIV, and then a positive ELISA, the ELISA, that fails to be confirmed by Western blot or EFIA should not be considered negative, and repeat testing should be done in 3 to 6 months. So just some nursing assessment that we can use. We want to do a comprehensive nursing assessment for pregnant individual with HIV/AIDS. We want to do a focus on assessing the mother's health, monitoring the pregnancy, and planning for the baby's delivery. So health include evaluating the mother HIV status, her viral load, CD4 count, and any opportunistic infection. The assessment also covers the mother adherence to the medication regimen, assess her mental health and social support, as well as the baby's growth and development while in utero. A viral load of less than 1,000 copies per ml is generally considered safe for vaginal delivery, while higher load may necessitate a C-section at this point. So just to look at some intervention in this section. So some intervention during the prenatal period is to institute measures to prevent opportunist infection, of course. Avoid any procedures that increase the risk of prenatal transmission, such as the amniocentesis and fetal scope sampling. And then during the intrapartum period, if the fetus has been exposed to HIV in utero, the highest risk exists during delivery, of course, through the birth canal. So avoid the use of internal scope, electrode for monitoring of the fetus. And then avoid episiotomy to decrease the amount of maternal blood and around the birth canal, of course. Then avoid the administration of oxytocin, because oxytocin increased contraction is induced by the oxytocin and can be strong. So those causing vaginal tears sometimes, or which would then necessitate an episiotomy. Place a heavy absorbent pad underneath the mother's hip to absorb any amniotic fluid and maternal blood. And then, of course, minimize the neonate exposure to maternal blood and body fluid by promptly removing the neonate from the mother blood after delivery. You will want to also suction fluid from the neonate immediately, and prepare to administer the zidovudine as prescribed to the mother during labor and delivery, as I mentioned before, for vaginal and cesarean delivery. Postpartum period, monitor for signs of infection. Place the mother in a protective isolation if she's immunocompromised. And then breastfeeding is most likely to be restricted following primary health care. And then, of course, you want to follow any primary health care provider. Recommendation regarding breastfeeding: teach the mother how to monitor for signs of infection and report any signs of infection if it does occur. For the newborn can also room with the mother. Sometimes mother wants to room with their baby. It's okay for them to room with the mother. It also depends on the agency procedures as well. And so you want to make sure you know what the hospital or the agency that you're working for, their policies and procedure pertaining to rooming. And the newborn may also be placed, as I mentioned before, in the NICU for the first 24 hours of life to complete baseline laboratory studies and to receive the initial treatment of the Zolvidone, the Zolvidone syrup, and any other initial treatment that needs to be done at that time. So just to continue, newborn of mother with HIV, the just to review immunization exposures. So the fetus that is born of a mother who is positive for HIV antibody should be monitored closely throughout the pregnancy. There should be a serial of ultrasound, or a series of ultrasound screening should be done during pregnancy. This is to identify in utero growth retardation, and then it should be done weekly non-stress testing after 32 weeks of gestation. And then of course a biophysical profile may be necessary during the pregnancy as well. So newborn that are born to HIV positive mother may test positive because the mother's antibodies may persist in the newborn for about 18 months after birth. So they may be test positive up to 18 months. The use of antiviral medication, the reduction of newborn exposure to maternal blood and body fluid, and early identification of HIV in pregnancy helps to reduce the risk of transmission to these newborns. So all newborn born to HIV positive mothers acquire maternal antibodies to HIV infection, but not all acquire the infection. The newborn may be symptomatic for the first 7 months to years of life. And then transmission typically across placenta barrier during labor and birth. And then breast milk breastfeeding is typically not done if the mother is HIV positive, following, and of course as I mentioned before, follow the healthcare provider prescription. So I just want to go over just some typical assessment also on this slide. Possibly no outward signs at birth, like signs of immune deficiency, hepatomegaly, splenomegaly, lymphadenopathy, impairment in growth and development. And then some interventions is to clean the newborn skin carefully before any invasive procedure, such as administration of phytonadione on the heel stick or venipunctures. If for some reason circumcisions are not done on newborns with HIV positive mother until the newborn status is determined. So when it comes to cultural, we might want to do some teaching in this area with circumcision, to educate the parent, to let them know that circumcision is typically not done at this time until we're able to identify the status of the newborn. And as I mentioned before, the newborn can room with mother if the hospital policy is allowed, and of course they will be in NICU up in the first 24 hours. And then all HIV exposed newborns should be treated with medication to prevent infection by pneumocystic gyrovectory. So the antiretroviral medication may be administered as prescribed for the first 6 weeks of life or longer if the healthcare provider deem it necessary. And then monitor for early signs of immune deficiency, such as enlarged spleen or liver, adenopathy, impairment in growth and development. And of course, we know the newborn is at risk of HIV infection, and this person should be screened after birth, and 1 week, 2 weeks, and 1 month, and then 2 months of age. We want to inform the mother that HIV culture is recommended 1 month and after 4 months of age. Just immunization with live vaccines such as measles, mumps, rubella, and varicella should not be done until the newborn infant or child status is confirmed. If the child is infected, live vaccine will not be given. So just to reiterate that again, immunization with live vaccines such as measles, mumps, rubella, and varicella should not be given to the newborn infant until the status is confirmed. If the child is infected, then we would not want to give that child live vaccine. So next we're going to look into, this is a part 2 of this slide. This section is talking about hadiform mole, eczema, Hodgkin disease, and laryngotracheobronchitis, otherwise referred to as croup. Let's talk about what really is hadiform mole, and then brief pathophysiology and clinical manifestation. So hadiform mole is a form of gestational trophoblastic disease that occur when the trophoblasts, which are the peripheral cells that attach the fertilized ovum to the uterine wall, develops abnormally. The mole manifests as an edematous grape-like cluster that may be non-malignant or may develop into a choriocarcinoma. So pathophysiology and clinical manifestation, as I mentioned, the mole may appear edematous, and then it's grape-like cluster, and then of course it progresses into a choriocarcinoma, which is a malignant form of trophoblastic disease. So some typical assessment is going to include fetal heart rate that is not detectable, vaginal bleeding, which may occur by the 4th week or not until the 2nd trimester. This is going to be bright red or dark brown in color, and may be slight, profuse, or intermittent. Might see some signs of preeclampsia, such as progressive blood pressure elevation before the 20th week of gestation. It's important to also note that preeclampsia usually occur after 20 weeks of pregnancy, so typically in the 3rd trimester. The fundal height will be greater than expected for gestational date, and then elevated human gonadotropin levels is going to be elevated. So the chorionic gonadotropin level is going to be elevated, and then characteristic, you're going to see like a snowstorm pattern shown when you're looking at the ultrasound. It's not going to be, of course, a fetus. You're going to see characteristic of a snowstorm pattern shown on that ultrasound. So here on this slide, you see a picture of what a hadiform mole looked like, and then of course they do evacuation of this from the uterus. So some typical intervention, we want to, as nurses, prepare the client for the uterine evaluation before the evacuation, and diagnosis tested are done to determine mastelic disease. Evacuation of the mole is done by vacuum aspiration. Oxytocin may be administered after evacuation, and this is typical just to help with contraction of the uterus. We want to monitor the patient for post-procedure, such as hemorrhage and infections. A sample of the tissue is sent to the laboratory for evaluation and follow-up. It's important to detect the changes suggestive of any malignancy. And of course, human chorionic gonadotropin levels are monitored every 1 to 2 weeks until it is normal. And then pregnancy levels are attained. Levels are checked every 1 to 2 months for 1 year. Instruct the client and her partner about birth control measures so that pregnancy can be prevented during the first 1 year after such procedure is done. The medication regimen include oxytocin for the constriction of the uterus, and measures to implement as well to prevent pregnancy up to 1 year. And as I mentioned, tissues are examined for malignancy. They take a sample, and of course they examine the tissue for any malignancy. And then if there are no malignancy detected, there are no additional follow-up that is needed at that time. So next we're going to look at eczema or dermatitis, the description and just some forms of different eczema. So overview of eczema. This is a superficial inflammatory process involving primarily the epidermis. There are many types, some of which include atopic dermatitis, contact dermatitis, and stasis dermatitis. This is sometimes associated with family history of the disorder, allergies, asthma, or allergic rhinitis. The major goal of management for eczema is to relieve the pruritus, lubricate the skin, and reduce the inflammation, and then of course prevent or control secondary infection. So forms of eczema is infantile, usually which is begin at about 2 to 6 months of age, and decrease in the incident with aging. So as they get older, sometimes this decreases or improve. And then where it goes into spontaneous remission may occur typically by the age of 3. We have childhood eczema as well. The infantile form occurs at 2 to 3 years of age. And then pre-adolescent and adolescent, which begin at about 12 years of age and may continue into early adult years of infancy. And as I mentioned before, some management objective is to just aim at relieving the itching or the pruritus, moisturize the skin, and thus help to reduce inflammation and prevent any secondary infection that may occur from pruritus and open skin, etc. So some assessment and clinical features for presentation. So eczema, as we know, is characterized by redness, scaliness, and itching. Lesions include firm pupils under 1 centimeter and fluid-filled vesicles, often accompanied by weeping, oozing, and crusting. So lesion can occur on the scalp and face of the infant. Creases of the elbow, knees, neck, wrist, and ankle are other creases between the buttocks and the legs. And so those are just some common sites and infectious indicators. So some intervention and care strategies include bathing and moisturizing protocol, medication and symptom management, irritant avoidance, and then parental guidance. So bathe and moisturize are important. Bathing water should be tapered, and bath should be limited to 5 to 10 minutes. And the skin should be moisturized immediately after the bath. With a thick cream or ointment should be used, such as petroleum jelly, for example. If topical medication are prescribed, they should be applied within 3 minutes after the bath is given. Antihistamine and topical corticosteroids may be prescribed as well. Corticosteroids are applied in a thin layer and are rubbed into the area thoroughly. Antibiotics may be prescribed if secondary infection occur. Avoid exposure to the skin. Any irritants such as irritating soap, detergent, fabric softener, diaper wipes, even some diapers can also trigger this, and then powder. Cool wet compress applied for short period of time may help to soothe the skin and alleviate itching. Want to pat dry the skin, do not rub this, and then implement any cooling treatment. Eliminate conditions that increase itching, such as wet diapers. Excessive bathing help to dry out the skin some more and make the condition worse. Ambient heat, wool clothing or blanket, and rough fabric or furry stuffed animals can also help to trigger or make the eczema worse. Exposure to latex should also be avoided. Instruct the parent to wash clothing in a detergent and to rinse them thoroughly. Putting the clothes through a second complete wash cycle without detergent can also help minimize any residue remaining on the fabric, and can also help with improving the eczema. You can instruct the parents about measures to prevent skin infection, and instruct the parents to monitor the lesion for signs of infection, unicolor crust with surrounding erythema, and to seek immediate medical intervention if such signs are noted. So now we're going to look at Hodgkin's disease, description, and pathophysiology. So Hodgkin's disease is a type of lymphoma. It is a malignancy of the lymph node that originates in a single lymph node or a single chain of nodes. The disease predictably metastasizes to a non-nodal or extra lymphatic sites, especially the spleen, liver, bone marrow, lungs, and mediastinum. Hodgkin's disease is characterized by the presence of the Reed-Sternberg cell noted in a lymph node biopsy specimen. Peak incidence is noted in mid-adolescent. Possibly cause include viral infection of previous exposure to alkylating chemical agents. The prognosis is excellent with long-term survival rate depending on the stage of the disease. The primary treatment modalities are radiation and chemotherapy. Each may be used alone or in combination depending on the clinical stage of the disease. Sorry, it's taking a little while for me to move to the next slide. So now we have the assessment of Hodgkin's disease and diagnostic finding. So of course it's a painless enlargement of lymph nodes. Primary clinical signs of Hodgkin's disease As I mentioned, is painless. Enlargement of the lymph node is typically firm, is non-tendered, and movable. Often found in the supraclavicle area. In children, the sentinel node near the left clavicle is commonly the first to enlarge. Non-productive cough due to mediastinal lymphadenopathy or enlarged lymph nodes in the mediastinum may compress the trachea or the bronchi, causing a non-productive cough, which is notably symptoms in Hodgkin disease. So advanced lymph nodes and extralymphatic involvement that may cause systemic symptoms such as low-grade or intermittent fever, anorexia, nausea, weight loss, night sweat, and pruritus. Positive biopsy specimen of lymph node with the presence, of course, the red Sternberg cells, and positive bone marrow biopsy specimen. A CT scan of the liver, spleen, and bone marrow may be done to detect if there's any metastasis. So, some intervention and management for Hodgkin's disease. Of course, early stage without mediastinal nodes involvement. The treatment of choice is extensive external radiation of the involved lymph node region, more extensive disease radiation, and multi-drug chemotherapy are used. We want to monitor for medication-induced pancytopenia and an abnormal depression of all cellular component of the blood, which can increase the risk for infection, bleeding, and anemia. Monitor for signs of infection and bleeding, and then we want to protect the child from infection, of course. Monitor for advanced effects related to chemotherapy or radiation. The most common adverse effect of extensive irradiation is malaise, which can be difficult for older children and adolescents to tolerate physically and psychologically. We want to monitor for nausea and vomiting and administer any antiemetic that is prescribed to help manage those symptoms. We also want to implement any hydration management as well for these patients. Next, we're going to look at laryngotracheal bronchitis, otherwise referred to as croup. We're going to look at the description and the etiology. So, laryngotracheal bronchitis, commonly known as croup, involved inflammation of the larynx, the trachea, and the bronchi. Primarily, this affects younger children. Etiology and common pathogens. The condition is mainly caused by a viral infection such as parainfluenza virus type 2 and 3, respiratory syncytial virus, otherwise referred as RSV, mycoplasma pneumonia, and influenza virus A and B. Clinical presentation. Croup typically has a gradual onset and often follows symptoms of upper respiratory infection, predominantly affecting children under the age of 5. So, some nursing intervention for this. We want to look at the gastrointestinal tract, like anorexia. So we want to encourage fluids and food as best tolerated by providing small frequent meals and monitor for weight loss. Nausea and vomiting, of course, we want to administer any antiemetics around the clock and monitor for dehydration. And then for mucosal ulceration, provide soothing oral hygiene and prescribe mouth rinses. Typically, anesthetic may be prescribed. And then if diarrhea occur, we want to administer any anti-spasmodic or anti-diarrhea preparation as prescribed, and of course monitor for dehydration. So just to continue with laryngotracheal bronchitis, otherwise referred to as croup, some assessment. On the slide we have 2 assessment noted, but there are 4 that we will that I will be sharing with you. So in stage 1, initial symptoms, patient may present with low-grade fever, hoarseness, a seal, bark, and a brosy cough or croup cough. Inspiratory stridor, fear and irritability, restlessness. Then in stage 2, want to do continuous, you may notice continuous restlessness, retraction, use of accessory muscles, crackles and wheeze, labored breathing or labored respiration. And then in stage 3, continued restlessness is going to be noted, anxiety, pallor, diaphoresis, tachypnea, signs of anoxia and hypercapnia. In stage 4, it will be intermittent cyanosis, progressing to consistent cyanosis, apneic episode, progressing to cessation of breathing. Then here we have some intervention in nursing care. Area management is going to include to maintain a patent airway, assess respiratory status, monitor pulse oximetry, monitor nasal flaring, sternal retraction, and inspiratory stridor. Monitor for adequate respiratory exchange, monitor for pallor or cyanosis. We want to elevate the head of the bed and provide rest. We want to provide on the oxygen therapy, humidified oxygen via cool air or mist tent as prescribed by for the hospitalized child. We want to also instruct the parent to use a cool air vaporizer at home. Other measures can include having the child breathe into a cool night air or the air from an open freezer, or taking the child to a cool basement or garage. We want to provide and encourage fluid intake for hydration. IV fluid may be prescribed to maintain hydration status if the child is unable to take in fluid orally. We want to administer analgesic as well to reduce fever. And then teach your parents to avoid administering cough syrup or cold medicine, which may dry and thicken the secretion. We want to give antibiotic as prescribed. This will not be administered unless there is indication that bacterial infection is present. We want to also administer corticosteroid if it is prescribed. This would help to reduce inflammation and edema. And then mixture of helium and oxygen can also be utilized. It's referred to as Ileus, and this is often to be prescribed. We want, as part of the emergency preparation and parental guideline, have a resuscitation equipment available and provide appropriate reassurance and education to the parents or the caregiver during this time as well. So just some key summary and takeaway of what we have discussed thus far. We looked at early recognition and diagnosis. We emphasized timely identification of conditions like adiform mole, eczema, Hodgkin disease, and croup. This is essential for effective treatment and improvement in patient outcome. Multidisciplinary management approach is essential. It's offer comprehensive care, involve clinical evaluation, of course, laboratory tests, imaging, pharmacologic therapy, and patient education to ensure holistic disease management. Want to do ongoing monitoring and parent education. Regular follow-up includes serial ACG for adiform mole. We want to do surveillance for complication in Hodgkin disease. We want to continue with patient education, support recovery, and prevention program where it is also needed. And there is just some reference and further reading that you could utilize along your studies as well. And then next we're going to go into phase 2. In phase 2, this is a comprehensive overview and nursing management of multiple myeloma, cholecystitis, histoplasmosis, sarcoidosis, and pericarditis. So multiple myeloma, just a description. This is a malignant proliferation of plasma cells within the bone. Excessive number of abnormal plasma cells invades the bone marrow and ultimately destroys the bone. Invasion of the lymph nodes is involved, spleen and the liver can occur. The abnormal plasma cell produces an abnormal antibodies referred to or is called myeloma protein or the Jones protein, and this is found in the urine, in the blood and the urine. Multiple myeloma causes decreased production of immunoglobulin and antibodies and increased levels of uric acid and calcium, which can lead to kidney failure. The disease develops slowly and the cause is unknown. So just to then continue with the introduction to the selected disease, multiple myeloma. As you look at the images on the screen, you see in the shape of the bone, bone marrow, the malignant proliferation of the plasma cells. Just to kind of give you a mental picture of what that might look like, the plasma cells in myeloma. And then, as I mentioned before, it's a malignant cell proliferation in the bone marrow causing bone destruction, and abnormal antibodies are produced, leading to immunodeficiency and potentially kidney failure as well. Just to take a look at cholecystic overview, we have a picture of the gallbladder and the liver, just anterior to the stomach. Cholecystitis is a gallbladder inflammation. It's chronic and it's often linked to gallstone or bowel emptying with a calculus form caused by bacterial invasion. And of course, I will go in a little bit more depth pertaining to both. So multiple myeloma, pathophysiology and description, and I'm just going to be repeating these. I'm aware of it. It helps for reinforcement as well. So malignant proliferation of the plasma cells. As I mentioned, multiple myeloma involve malignant plasma cells that proliferating within bone marrow, leading to bone destruction and possible invasion of the lymph nodes, spleen, liver as the disease advances. Abnormal antibodies production and disease effects. So abnormal plasma cell produce myeloma protein, detectable both in the blood and the urine, causing disease, normal immunoglobulin immunodeficiency. Uric acid and calcium may result in kidney stones. And another image that I presented here, the clinical assessment. Bone and skeleton pain, especially in the ribs, spine, and pelvis. Weakness and fatigue is eminent. Anemia and urinalysis will show the Jones protein in your urine. An elevated total serum protein level is going to be elevated as well. osteoporosis, which is bone loss and the development of pathological fractures, thrombocytopenia and leukopenia, elevated calcium and uric levels can lead to kidney failure, spinal cord compression, and paraplegia. Bone marrow aspirate will show an abnormal number of immature plasma cells. Is it also important to just highlight that client with multiple myeloma is at risk for pathological fractures? Therefore, we want to provide skeleton support when we are moving this patient or turning them or ambulating them. We want to ensure to provide also like a hazardous-free environment to prevent any additional injury to these patients. So just to go on to the intervention, some nursing intervention that we can utilize. We want to administer chemotherapy as prescribed. We want to provide supportive care to control symptoms and prevent complication, especially bone fractures, hypercalcemia, and kidney failure and infections. We want to maintain neutropenic and bleeding precaution as necessary. We want to monitor for signs of bleeding, infection, and skeletal fracture. We want to encourage consumption of at least 2 liters of fluid per day. This is just to offset the potential problem associated with hypercalcemia, hyperuricemia, and proteinuria. And encourage additional fluid as indicated and as tolerated. We want to monitor for signs of kidney failure, collect 24-hour urine as prescribed by the healthcare provider, and encourage ambulation to prevent renal problem and to slow down bone reabsorption. We want to administer IV fluid and diuretic as prescribed, this to increase renal excretion of the calcium, and administer blood transfusion if this is prescribed for anemia, and then administer any analgesic prescribed and provide non-pharmacological therapy to control pain. We want to administer antibiotic if this is prescribed for infection, and prepare the client for local radiation therapy if this is also prescribed. Instruct the client in home care as well. So any signs and symptoms of infection, we administer biphosphonate medication to slow down bone damage and reduce pain and risk of the fracture. And that's just basically went over the pain and additional support for these patients who have multiple myeloma. So some additional information with intervention. As I mentioned before, the chemotherapy administration, and make sure the patient is comfortable. We want to provide teaching and then provide the chemotherapy as it is prescribed to reduce any malignant plasma cells in the bone marrow. And then of course we want to follow the specific treatment regimen as it is prescribed. We want to offer any supportive care and management wherever is needed by providing care to control symptoms and anything that we need to do to therapeutically support our patient. So next we're going to look at cholecystitis, the pathophysiology and the description. So to start with the description, this is an inflammation of the gallbladder that may occur as an acute or chronic process. Acute inflammation is associated with gallstone. Chronic cholecystitis is result from inefficient bowel emptying and gallbladder muscle wall disease caused by a fibrotic and constricted gallbladder. So as acalculous cholecystitis occur, this is gallbladder inflammation without the gallstone or bowel stasis. In the presence of gallstone and is caused by in the absence of gallstone and is caused by a bacterial invasion by the lymphatic or vascular system. Okay, and then if we just review what's presented on our slide, In acute and chronic inflammation, cholecystitis, as I mentioned, involves inflammation of the gallbladder present as either acute or chronic. Acute inflammation is commonly linked to gallstone, while chronic inflammation results from impaired bowel emptying and gallbladder wall dysfunction, causing fibrous and contractions. And then the role of the gallstone in acute cholecystitis, as I mentioned, acute cholecystitis is primarily caused by gallstone obstruction bowel flow, which trigger inflammation within the gallbladder. And then pathogenesis of the chronic and acalculous cholecystitis. Chronic cholecystitis developed due to prolonged bowel stasis and muscular dysfunction, leading to fibrosis. Acalculous cholecystitis occur without the gallstone, caused by bacterial invasion through lymphatic or vascular route. So just some assessment that we could go over. Nausea and vomiting, indigestion, belching, flatulence, epigastric pain that radiates to the right shoulder or scapula, pain localized in the right upper quadrant and triggered by high fat or high volume meal, and then guardian rigidity and rebound tenderness. Masses palpated in the right upper quadrant. Of course, the Murphy sign the person will not be able to take a deep breath when the examiner finger are passed below the hepatic region because of the pain. You may noted elevated temperature. You may note tachycardia and signs of dehydration as well. So clinical assessment and biliary obstruction. You may notice jaundice, dark orange foamy urine, steatorrhea, and clay-colored feces with pruritus or itching. And on our slide, just a little more information, same thing as I noted. Clinical presentation of cholecystitis typically present with nausea, as I mentioned, vomiting, indigestion, belching, flatulence, epigastric pain, radiation to the right shoulder or scapula. The pain is localized in the right upper quadrant and is often triggered by high fat or large meals. Physical and systemic signs on physical examination may reveal guardian of the area, rigidity to the area, rebound tenderness at the area, and a palpable mass in the right upper quadrant. The Murphy sign is positive, since systemic signs include elevated temperature, tachycardia, and dehydration. Manifestation of biliary obstruction or biliary obstruction present with jaundice, dark orange foamy urine, as I mentioned, steatorrhea, clay-colored stool, pruritus or itching, indicating complicating cholecystitis. Okay. So some nursing intervention, surgical management for cholecystitis. We want to maintain NPO status during nausea and vomiting episode. We want to maintain an NG decompression as prescribed for severe vomiting. And then, of course, we want to administer any antiemetic as prescribed for the nausea and the vomiting. We want to also administer any analgesic as prescribed to relieve the pain and reduce the spasm. Any antispasm we want to administer, such as anticholinergic as prescribed to relax any smooth muscle. And then instruct the client with chronic cholecystitis to eat small, low-fat meal. And then instruct the client to avoid gas-forming food. We want to prepare the client for non-surgical and surgical procedure as prescribed. So some surgical intervention for cholecystectomy is cholecystectomy, which is the removal of the gallbladder. And then colorectomy, which is require incision into the common bile duct to remove any stones. And this is surgical procedure that may be performed via a laparoscopy. And just some post-operative intervention. We want to monitor for respiratory complication, of course, that could cause by pain at the incision site. We want to encourage coughing and deep breathing, encourage early ambulation, and instruct the client about splinting the abdomen to prevent discomfort and adhesion during coughing. We want to administer any antiemetic as prescribed for nausea and vomiting, which also would take the pressure off the wound, and then administer any analgesic as prescribed to relieve the pain. Of course, maintain NPO status, NG tube suctioning as prescribed. And then as prescribed, we advance the diet from clear liquid to solid when it is prescribed and is able to tolerate it after gag reflex. Maintain and monitor drainage from the tube if present. T-tube is a medical device that is typically used in the biliary surgery. It provides a temporary drainage route for bile. It is inserted into the bile duct to allow for the bile to drain outside the body. So it's just a temporary route for the bile to be able to drain out of the body. They put in place the T-tube. So, overview of histoplasmosis and sarcoidosis. So histoplasmosis is a pulmonary fungal infection. It's caused by spores of the Histoplasma capsulotum. Transmission occurs by halation of spores, which commonly are found in contaminated soil. Spores are also usually found in bird dropping as well. And then for sarcoidosis, this is the presence of epithelioid cells, tubercles in the lungs. The cause is unknown, but it's a high titer of Epstein-Barr virus may be noted. So viral incidence is higher in African Americans and young adults. So clinical features and diagnosis for sarcoidosis is characterized by, as I mentioned before, the epithelioid cells, tubercles in the lungs, which is with an unknown etiology possibly linked to Epstein-Barr virus. And I already mentioned it's predominant in African American and young adults. Symptoms include night sweats, fever, cough, dyspnea, skin nodules, and polyarthritis. The key vein test involving intradermal injection of a sarcoid antigen produces a nodule lesion after about 1 month, aiding which then help to facilitate the diagnosis of sarcoidosis. And just some nursing care for sarcoidosis patients. So just a little bit more in depth, the description and assessment. So as I mentioned, it's a pulmonary fungal infection caused by spore of the Histoplasma capsulotum. Transmission occurs by inhalation of spores, which commonly are found in contaminated soil. And then spores are usually found in bird dropping as well. On the assessment, you're going to see similar to pneumonia, positive skin test for histoplasmosis, positive agglutination test, and splenomegaly or hepatomegaly may be noted as well. So intervention is to administer oxygen as prescribed and monitor breath sound. Administer any antiemetic for nausea and vomiting, any antihistamine, antipyretic, and corticosteroid as prescribed for the inflammation. Administer fungicidal medication as prescribed. Want to encourage coughing and deep breathing. Want to place the client in a semi-fowler position and monitor vital signs. Monitor for nephrotoxicity from the fungicidal medication, and then instruct the client to wear a mask and spray the floor with water before sweeping barn and chicken coops, if this is applicable. And though I've mentioned the description for sarcoidosis, as I mentioned, is the presence of the epithelioid cell tubercles in the lungs. The cause, as I noted, is unknown, but it's a high titer of Epstein-Barr virus may be noted. Viral incidence is higher in African American and young adults. The assessment noted is night sweat, as I mentioned in the previous slide, fever, cough, and dyspnea, skin nodules, polyarthritis, key vein test, sarcoid node antigen is injected intradermally and this causes a local nodule lesion in about 1 month. Some interventions is to administer the corticosteroid to control the symptoms. We want to monitor temperature and increase fluid. Provide frequent rest period and encourage small, frequent, nutritious meals. So next we're going to look at the pericarditis. So the description is this is an acute or chronic inflammation of the pericardium. Chronic pericarditis is a chronic inflammatory thickening of the pericardium, constricts the heart, causing compression. The pericardial sacs become inflamed. Pericarditis can result in the loss of pericardial elasticity or an accumulation of fluid within the sac. Heart failure or cardiac tamponade may result. So this is a real serious medical emergency. On assessment, what we'll note is pain in the anterior chest that radiates the left side of the neck, shoulder, or back. Pain is great and is aggravated by breathing, particularly during inspiration, coughing, and swallowing. Pain is worse when in a supine position and may be relieved by leaning forward. So you might see the patient in like a tripod leaning forward position. Pericardial friction rub, scratching high-pitched sound is audible on auscultation and is produced by rubbing of the inflamed pericardial layer. Fever and chills, fatigue and malaise, elevated white blood cell count, electrocardiographic change with acute pericarditis. Then ST segment elevation will also be noted with onset of inflammation. Arterial fibrillation is also common. Signs of right ventricular failure in client with chronic constrictive pericarditis is evident. So assessment, you're gonna, as I mentioned, pain in the anterior chest that radiates the left side of the neck, shoulder, and back. Pain is great and is aggravated by breathing, particularly during inspiration, coughing, and swelling, as I mentioned before. And then pain is worse when the person is supine, in a supine position that may be relieved by leaning forward. Pericardial friction rub, which is a scratchy high-pitched sound that is heard on auscultation, is produced by the rubbing of the inflamed pericardial layer. As I mentioned, fever and chill, fatigue and malaise is evident, and then elevated white blood cell. You see that electrocardiographic changes with acute pericarditis. You're going to see ST segment elevation with onset of inflammation, and arterial fibrillation is also common. Signs of right ventricular failure in client with chronic constrictive pericarditis. Intervention, you want to assess the nature of the pain. Place the client in a high Fowler position or upright and leaning forward. Administer oxygen. Administer non-steroidal anti-inflammatory drug or corticosteroids for pain as prescribed. We want to auscultate for pericardial friction rub and check residual of blood culture to identify the causative organism. If it is is it bacterial, we want to administer antibiotic for bacterial infection as prescribed. Administer diuretic and digoxin as prescribed to the client with chronic constrictive pericarditis. Surgical incision of the pericardium, we call pericardial window, or pericardiectomy may be necessary. We want to monitor for signs of cardiac tamponade and notify the primary healthcare provider if signs of cardiac tamponade does occur. So next we're going to review some comprehensive overview when it comes to cardiac tamponade, polycystic kidney disease, chronic kidney disease, glaucoma, and retinal detachment. So cardiac tamponade, what is this? It is a pericardial infusion that occurs when the space between the parietal and the visceral layer of the pericardium is filled with fluid. Pericardial effusion places a client at risk for cardiac tamponade and accumulation of fluid in the pericardial cavity, as noted before. Tamponade restrict ventricular filling and cardiac output drops. Acute cardiac tamponade can occur when small volume 20 to 50 ml of fluid accumulate rapidly around the pericardium. And I've already went over the definition of pericardial effusion, the mechanism of fluid accumulation. As I mentioned, fluid buildup in the pericardial cavity, which can lead to cardiac tamponade by restricting the ventricular filling. Impact on cardiac output, which cardiac tamponade decreases the cardiac output due to impaired ventricular filling and reduced stroke volume. And the characteristic of acute tamponade occur when a small volume of fluid rapidly accumulate, causing sudden cardiac output decline. So on assessment, pulsus paradoxus. This is an abnormal drop in systolic pressure, stroke volume, and pulse wave amplitude during inhalation. It's defined as a systolic pressure drop of more than 10 during, which is millimeter of mercury, of course, during inspiration. Is not related to heart rate or pulse rate. Paradoxus can be a sign of condition that makes it hard for the heart or lung to function, or involve blockage or narrow area in the heart or lung. Increase cardiac volume output or central venous pressure, jugular venous distension with clear lungs, distant muffled heart sounds, decreased cardiac output, and narrowing pulse pressure. So increase in central venous pressure is noted, jugular vein distension with clear lungs, distant muffled heart sounds, and decreased cardiac output, and then a narrow in the pulse pressure is also noted. So we can do chest x-rays and electrocardiography are essential for detecting pericardial effusion and assessing for cardiac functioning as part of the diagnostic and evaluation tool. So some nursing intervention. Client needs to be placed in a critical care unit for hemodynamic monitoring. We want to administer fluid intravenously as prescribed. Manage decreased cardiac output, and then prepare the client for chest x-ray or echocardiogram. Prepare the client for pericardiocentesis to withdraw pericardial fluid if it is prescribed, and monitor for recurrency of tamponade following the pericardiocentesis. If the client experienced recurrent tamponade or recurrent effusion, or develop adhesion from chronic pericarditis, a portion or all of the pericardium may be removed. It's called pericardiumectomy. And this is to allow adequate ventricular filling and contractions. And on the third image to the right, you see the pericardiocentesis preparation, where they put the needle in to withdraw excess fluid buildup around the pericardium. So on this slide, this is polycystic kidney disease. I have three different pictures, just showing an overview and types. This is a cyst formation and hypertrophy of the kidney, which leads to cystic rupture, infection, formation of scar tissue, and damaged nephrons. There is no specific treatment to arrest the progress of the destructive cyst. The ultimate result of this disease is chronic kidney disease. Types is infantile polycystic disease, an inherited autosomal recessive trait that result in the death of the infant within a few months after birth. Adult polycystic disease is an autosomal dominant trait that manifests between the age of 30 and 40 years and result in end kidney disease. So, for the infantile polycystic disease, as we know, it is inherited. Is an autosomal recessive trait that results in the death of the infant within a few months. And then adult polycystic disease is also autosomal, that's dominant trait that typically manifests between the age of 30 and 40. And the result of that is end stage kidney disease. So ultimately, death or kidney transplant. So assessment of polycystic kidney disease, often asymptomatic until the age of 30 to 40 years. Flank lumbar abdominal pain that worsens with activity and is relieved with lying down. Fever and chills, recurrent UTIs, hematuria, proteinuria, pyuria, calculi, hypertension, palpable abdominal mass, and enlarged kidney. Some intervention for gross hematuria, which indicates cyst rupture. Increased sodium and water intake because sodium loss rather than retention occur. Provide bed rest if ruptured cysts and bleeding occur. We want to monitor pain, teach the use of pain medication, and teach to avoid NSAID in this situation. Aspirin, such as aspirin, because of the risk for bleeding. And use dry heat to the abdomen and flank area for comfort measures when the cyst is infected. We want to prevent constipation from pressure of the cyst on the colon by adequate fiber in diet. Or we can provide stool softener and adequate fluid intake. We can encourage exercise as well and prepare the client for percutaneous cyst puncture for relief of obstruction or for the drainage of the abscess to relieve the pain. We want to administer any antihypertensive as prescribed to prevent and or treat UTI, and then prepare the client for dialysis or renal transplantation, as I noted earlier. Encourage the client to seek genetic counseling, provide psychological support to the client and the family, provide psychological support and genetic counseling for family member without polycystic kidney disease who may want to donate their kidney for their loved one. And then, as I know, the chronic kidney disease, This is a slow, progressive, irreversible loss in kidney function with the GFR less than or equal to 60 ml per minute for 3 months or longer. So it is a slow, progressive, irreversible loss in kidney function with the GFL less than or equal to 60 ml per minute for 3 months or longer. It occurs in stages with loss of 75% of functioning of the nephron. The client becomes symptomatic and eventually result in uremia or end-stage kidney disease with loss of 90 to 95% of the function of the nephron, which we know is the functional unit of the kidney. Then hypervolemia can occur because of the kidney inability to excrete sodium and water. And hypovolemia can occur because of the kidney inability to conserve sodium and water. So chronic kidney disease affects all major body systems and may require dialysis or kidney transplantation to maintain the person's life. Some primary cause may follow acute kidney injuries, diabetes mellitus, and other metabolic disorder, hypertension, and chronic urinary obstruction. Recurrent infection can also be a contributing factor, and then arterial occlusion or autoimmune disorders. Some assess body system for the manifestation of chronic kidney disease, assess psychological changes, which could include emotional liability, withdrawal, depression, anxiety, denial, dependency, etc. So independence, conflict, changes in body image, and suicidal behavior. So psychological assessment is also very crucial with monitoring this patient. Now we look at interventions, assessment and nursing management of chronic kidney disease. So systemic and physiological impact assessment. Assess multiple body system for chronic kidney disease manifestation and monitor psychological changes such as emotional liability, depression, anxiety, denial, suicidal behavior. Dietary management strategies. Implement a prescribed diet with moderate protein, high carbohydrate, low potassium, low phosphorus. Provide oral and skin care to prevent stomatitis and pruritus. Educate patient on fluid restriction and daily weight monitoring. Managing anemia in chronic kidney disease. Monitor hemoglobin and hematocrit levels. Administer erythropoiesis stimulating agents and folic acid. Provide oral iron with stool softener and limit blood transfusion to necessary cases to avoid complications. Address bleeding risk. Monitor for gastrointestinal bleed. Urea is broken down by the intestinal bacteria to ammonia. Ammonia irritates the GI mucosa, causing ulceration and bleeding. So monitor for decreased hemoglobin and hematocrit level as mentioned before. Avoid administration of acetylsalicylic acid because it exaggerates by the kidney if administered, like aspirin toxicity can occur and prolong the bleeding time. Place the client with chronic kidney disease on continuous telemetry. The client can also develop hyperkalemia, resulting in the risk for dysrhythmia. Glaucoma and retinal detachment overview and assessment and intervention. Types and pathophysiology of glaucoma. Glaucoma involve increased intracranial pressure due to impaired aqueous humorous drainage or overproduction, damage in the optic nerve, and causing vision loss. Primary open angle glaucoma result from trabecular meshwork obstruction, while primary angle closure glaucoma is caused by blockage of aqueous flow, often triggered by lens or pupil change, and this is a medical emergency. Acute closure glaucoma emergency. This is a medical this is a medical emergency characterized by sudden eye pain, nausea, and vomiting. Immediate treatment to lower intraocular pressure is critical to prevent permanent vision loss. Symptoms include blurred vision, halos around lights, and eye redness, requiring urgent medication and possible peripheral iridectomy surgery. Symptoms of retinal detachment. Retinal detachment symptoms typically include sudden onset of floaters, flashes of light, and shadow of curtain effects over the visual field. Prompt recognition and treatment are essential to preserve vision. So surgical treatment care, surgical intervention include for glaucoma include peripheral iridectomy to restore the aqueous humors, and then post-operative care include lifelong medication to control intraocular pressure and patient education to avoid drug that increased the intraocular pressure. Retinal detachment cause and assessment and treatment. Description of retinal detachment. Is separation of the retina from the epithelium. Occurs when the layer of the retina separate because of accumulation of fluid between them, or when both retinal layer elevate away from the choroid as a result of tumor. Partial detachment become complete if untreated. When detachment occur, complete blindness will happen. So here in this picture, you see what a healthy eye look like versus a retinal detachment. You can see the retina actually detaching, the detachment of the retina in the second picture. So fluid accumulation happens due to fluid buildup between the retinal layer, causing separation and elevation from the underlying structure. If untreated, this can progress from partial to complete detachment and potentially resulting in blindness. Tumor-induced retinal elevation. Tumor can cause both retinal layer to elevate away from the choroid, disrupting normal retinal adherence to the and contributing to retinal detachment. So assessment, as I mentioned before, flashes of light, floaters, or black spot. This is indicating a sign of bleeding. Increase in blurred vision, sense of curtain behind being drawn over the eye, loss of portion of the visual field, and painless loss of central or peripheral vision. So immediate intervention, provide bed rest, ensure bed rest to prevent further retinal detachment. Cover both eyes, apply patches to both eyes to limit movement and reduce stress. Communicate clearly, speak before approaching the client to avoid startling and explaining your care or your steps that you're providing. And then position the head properly, maintain prescribed head position to minimize retinal strain. And then avoid any jerky movements, which prevent sudden head movement to protect the retina from worsening. Preparation for surgical treatment. You want an explanation of the surgical procedure. Explain the surgical intervention clearly to the client to alleviate fear and set realistic expectation for the treatment. And preoperative care measures. Implement prescribed preoperative care, including bed rest, eye protection, and head stabilization to prevent worsening of the retinal detachment. Ensure informed consent, which is where we come in. Obtain informed consent by ensuring the client understands the surgical nature, risk, and benefit, and post-operative care that is explained to them by the surgeon prior to the procedure. We just want to ensure that they do understand what is being done, and that they do understand the risk and the benefit, and that they are actively alert and oriented and understanding what is going on, and then we co-sign or witness the consent. So surgical procedure, fluid drainage and retinal reattachment. Drainage of subretinal fluid. This procedure involves removing fluid from the subretinal space to allow the retina to reattach to its normal where it was normally. Then anatomical position, reversing retinal separation. Cryosurgery for retinal sealing. So cryosurgery applies a cold probe to the sclera, inducing inflammation that promote adhesion formation to seal the retinal break and prevent further detachment. And then diatherapy technique for adhesion. Diathermy uses electrode needle to deliver heat through the sclera, stimulating an inflammatory response that facilitate adhesion and secure the retina. Laser therapy and sclera buckling. Laser therapy induces an inflammatory response to seal small retina tear, preventing detachment progression by creating adhesion that stabilizes the retina. Sclera buckling. Sclera buckling places a supportive splint around the eye, mechanically holding the choroid and retina together until scar tissue forms to close the retina tear. So post-operative intervention, insertion of gas or silicone. Also, gas surgical procedure using the gas or silicone oil insertion. Insertion of gas or silicone oil is performed to support the retina by holding it in place during the healing process. Mechanism of action. These agents act as an internal tamponade, pressing the detached retina against the underlying tissue to facilitate reattachment. Purpose of the procedure. The primary goal is to promote retinal reattachment and ensuring proper holding reattachment. So this is my first YouTube video. I just want to thank you guys for taking your time out, and hopefully my notes have been served to be helpful in one way or another. Thank you so much.